Welcome to the Hospital Medicine Unplugged podcast.
Great to be here.
Today we're setting aside some of the more common inpatient diagnoses.
Right.
We're focusing instead on a really high acuity complex population. These patients need precise, evidence-based management.
Absolutely.
We're talking about patients presenting with sickle cell vaso-occlusive crisis, or VOC.
Yeah, a critical topic for any hospitalist.
Our mission in this deep dive is essentially to synthesize the latest protocols, tackle some of those areas of clinical uncertainty we all face, and provide you, the hospitalist listening, with immediately actionable insights, for managing these acute presentations efficiently and, importantly, safely.
And I think this is arguably one of the most critical discussions we can have in hospital medicine.
I agree.
Because while we often focus on the sheer volume of common conditions like, say, heart failure or COPD,
Right.
the complexity and the resource intensity of sickle cell disease, SCD, it really demands our focused attention.
It does.
We know SCD, it's that autosomal recessive inheritance of the go-globin gene mutation, affects about 100,000 people in the U.S. alone.
That's a significant number.
It is. And that population, they drive a really significant portion of inpatient admissions. VOC, the vaso-occlusive crisis, that's the hallmark acute complication.
The defining feature, really.
Exactly, characterized by these recurrent severe pain episodes. And they're what drive morbidity, repeated hospitalizations, and tragically, early mortality.
Yeah.
Even with all our modern advancements, the average life expectancy for patients with SCD is still... It's shockingly about 20 years shorter than the general population.
20 years. That's stark.
It is. So how we handle this acute crisis, it directly impacts their whole long-term health trajectory.
That context really sets a high bar for us for excellence in acute management. Before we jump straight into interventions, let's maybe ground ourselves firmly in the pathophysiology, because understanding the mechanism, I think, helps us choose our therapeutic targets wisely. We all know the basic premise. It's the polymerization of hemoglobin S, HbS, right? Especially under deoxygenated conditions.
Right.
Which leads to those rigid, sickled red blood cells.
Yeah.
But as you said, it's more than just simple clogging of the microvasculature.
Oh, absolutely. Thinking of it as just a plumbing problem, it really misses the profound systemic consequences.
Okay.
This pathology, it's a truly vicious cycle. It involves multiple factors. Yes, the rigid sickled red blood cells, the RBCs, they do initiate microvascular occlusion.
Causing ischemia of the pain.
Exactly. Tissue ischemia and that excruciating pain that brings the patient straight to the hospital.
Right.
But at the same time, these sickled RBCs, they interact abnormally with the vascular endothelium.
How so?
Well, they increase the expression of adhesion molecules. So they start sticking to platelets, leukocytes, the vessel walls themselves. And crucially, as these sickled cells hemolyze, break down, they release free hemoglobin and right into the plasma.
And that free hemoglobin is trouble.
Big trouble. It's a potent scavenger of nitric oxide, NO, which, as you know, is our body's essential natural vasodilator.
Right. Keeps things open.
Exactly. So NO depletion leads straight to endothelial dysfunction, rampant vasoconstriction, and it fuels this state of chronic inflammation and oxidative stress.
So it's not just the current crisis.
No, it sustains the current crisis, and it lays the groundwork for long-term organ damage, kidneys, lungs, brain.
That systemic inflammation, that endothelial damage, it makes the diagnostic step, I find, particularly challenging for the admitting team. And this is maybe our first major clinical pearl for the hospitalist listening. The diagnosis of VOC is fundamentally, solely clinical.
That's the key takeaway.
Patient-reported pain is the criterion standard, full stop. There are no reliable objective lab tests, no imaging findings that can definitively distinguish a true VOC from other causes of pain in someone with SCD.
And that inability to objectively verify the crisis creates tremendous friction at the bedside.
Yeah.
You simply cannot rely solely on vital signs or a patient's white count or routine labs as your sole diagnostic criteria for a pain crisis.
Because they can be misleading.
Entirely misleading. Leukocytosis, fever, they're often present in an uncomplicated VOC just due to that underlying inflammatory state we talked about.
Right.
Makes them completely non-specific.
Right.
So the real purpose of that initial assessment, therefore, isn't necessarily to confirm the VOC. The patient has already confirmed that for us by presenting with their typical pain.
Right.
It's to immediately assess for concurrent or alternative life-threatening complications.
Okay, so rule out the zebras first.
Exactly. We must quickly rule out infection, acute chest syndrome, splenic sequestration, maybe multi-organ failure. because those demand separate urgent management protocols. They go way beyond simple analgesia.
So if the pain is atypical somehow,
Yeah.
location, severity.
Yes. Atypical pain location, uncharacteristic severity, or maybe pain that's just refractory to their usual home measures, that must always trigger that differential diagnosis search immediately.
Okay, crucial point. So let's unpack those initial, really time-sensitive interventions. When that patient hits the door, the most critical element, arguably, is rapid administration of analgesia.
Without a doubt.
Management has to center on rapid triage, timely administration of parenteral opioids. And the guideline is stringent, right? Increasingly used as a quality metric.
It is.
Ideally, this needs to happen within 60 minutes of presentation.
The 1-hour rule. Speed is essential, absolutely. But the strategy is equally crucial. We absolutely must individualize opioid dosing.
Individualize, meaning?
Meaning basing our initial dose on the patient's prior effective regimens.
Yeah.
What doses, what schedules worked for them during their last crisis, not defaulting to some strict weight-based formula or, a generalized protocol derived from non-SCD pain literature.
And there's data supporting that.
Yeah, compelling data showing that this individualized approach, it's associated with lower overall admission rates.
Interesting. Why?
Likely because it prevents the patient from getting stuck in that awful cycle of pain escalation and undertreatment right at the start.
Okay. Now, I know many hospitalists, myself included sometimes, struggle with the operational piece of this. How do we quickly, reliably access and validate that prior effective regimen, especially when they arrive in the ED late on a Friday night?
That's the challenge. It really requires structured protocoling and ideally robust EMR integration. Ideally, the outpatient hematology team has documented an individualized written pain contract or protocol, something flagged clearly in the electronic medical record.
But if that's not available,
then the immediate goal is communication. You need to rapidly try and consult with the patient's outpatient hematologist, maybe their primary care provider, or at least review prior hospital charts to establish that benchmark dose.
And if you're still unsure?
When in doubt, it's often actually safer to start slightly higher and be prepared to titrate down rapidly rather than starting too low and letting the crisis escalate.
Makes sense.
But the key is frequent reassessment. Essential. Every 15 to 30 minutes initially until you achieve adequate analgesia. Because undertreatment, we know, dramatically increases patient anxiety. Right. Leads to a surge in catecholamines, stress hormones, and those only promote further sickling. It's counterproductive.
Okay, so individualize, assess frequently. Beyond the primary opioid strategy, what about adjunctive therapies?
Good question. NSAIDs like ketorolac or ibuprofen, they're pretty standard and should definitely be used when not contraindicated.
Thinking kidney function, bleeding risk.
Exactly. Underlying renal status, bleeding risk, maybe active peptic ulcer disease. But if those aren't issues, they're very helpful. We can also integrate some limited evidence-based supportive modalities. Things like massage or, interestingly, virtual reality have shown some promise.
But these are strictly adjuncts.
Strictly adjuncts. They do not replace that core opioid analgesic strategy.
Got it. And what about the really tough cases? Refractory pain.
Yeah, for those highly specific situations, maybe only say 5 to 10% of cases where the pain is genuinely refractory to massive doses of conventional opioids, there are conditional recommendations.
Well, yeah.
Things like low-dose ketamine infusions or, in very rare circumstances, maybe regional anesthesia, but not routine.
Definitely not routine.
Great.
These interventions carry complexity, significant risks, and they should always be reserved for select patients. And importantly, initiated only with specialist input pain team. Palliative care.
Okay.
It really reinforces the need for protocols that allow for careful, considered escalation rather than just reflexive, potentially high-risk interventions when the usual plan isn't working immediately.
Okay, that's clear. So if we've hopefully secured the pain control early on, our attention naturally shifts immediately to core supportive measures, particularly fluid management.
Yes, hydration. Vital.
Great.
Correct any hypovolemia that might have triggered the crisis in the first place, and also reduce sickling risk just by improving blood flow, reducing viscosity.
And for decades, the standard fluid was just normal saline NS, almost unquestioned in the inpatient setting.
Right. And here's where practice is really starting to shift, or at least where the discussion is happening. It's essential for hospitalists to be aware of this emerging research.
There is growing evidence suggesting that balanced fluids, think lactated ringers, LR, might actually be preferable to normal saline.
Interesting. Why? What's the rationale there?
The rationale is highly focused on mitigating that acidosis we touched on earlier. Normal saline, it's heavily concentrated in chloride, right?
Right, 154 LQCal.
Exactly. And when you give large volumes, that chloride load can lead straight to a hyperchloremic metabolic acidosis.
Okay, and connecting that acidosis back to the sickle cell pathophysiology.
Yeah.
What's the specific clinical consequence we're trying to avoid there?
Well, the drop in pH, that acidic environment, theoretically, it favors the deoxygenation of HBS.
Which is the trigger for polymerization.
Precisely the trigger for polymerization and sickling. So the idea is that LR, being a balanced solution with much less chloride, might mitigate the risk of inducing or worsening that hyperchloremic metabolic acidosis. It might keep the environment less favorable for sickling.
That makes biological sense. It sounds compelling.
It does, but we have to acknowledge the clinical reality here. Practice patterns still heavily favor NS in many, many centers.
Right.
And that reflects the ongoing uncertainty. We don't yet have that definitive, large-scale randomized trial data clearly establishing the superiority of LR in terms of hard clinical outcomes for VOC.
So the jury is still out, technically. NS persists because of inertia and lack of definitive proof for LR.
Pretty much. But clinicians should absolutely be aware of the potential advantages of LR, especially maybe in patients who have a known propensity for acidosis, or perhaps those requiring very large volumes of resuscitation fluid.
Makes sense to consider it.
But regardless of the fluid type you choose, NS or LR, the general rule is paramount. The primary goal is maintain euvolemia. Get them hydrated, but absolutely avoid fluid overload.
That's a huge pitfall.
Huge. We need to be intensely vigilant, particularly in patients with known comorbidities like cardiac dysfunction, pulmonary hypertension, or any underlying renal injury. Overzealous fluid administration can rapidly precipitate acute chest syndrome or frank heart failure.
Turning an uncomplicated pain crisis into
a life-threatening emergency, exactly. Careful ins and outs, daily weights, frequent lung exams are key.
Okay, shifting focus now to monitoring during the stay and, importantly, mitigating iatrogenic risks. Let's talk labs. What initial labs are truly essential to establish a baseline? And crucially, what practices should we maybe eliminate once the patient is stable?
Good question. Initially, baseline labs are important. You need a complete blood count, a CBC with differential. A reticulocyte count is critical to see if the marrow is responding. LDH lactate dehydrogenase as a marker of hemolysis, maybe a hemolysis index or haptoglobin, bilirubin, just to assess their baseline chronic anemia and the degree of ongoing crisis-related hemolysis.
Okay, that makes sense for admission.
But once that baseline is established, here's a really critical efficiency and safety point. This should be standardized across hospital protocols if possible. We must stress the recommendation to avoid routine daily laboratory testing in clinically stable patients.
You're flagging iatrogenic anemia here, right? That common trap. How often does that unnecessary daily blood draw truly impact these patients?
It happens far more frequently than we probably realize or acknowledge. Patients with SCD, they're already living with chronic anemia, sometimes quite severe,
Right.
and they are frequently hospitalized. Drawing frequent blood samples, often volumes of 5, maybe 10 milliliters every single day, it rapidly accumulates to significant blood loss over a week-long admission.
Yeah, it adds up fast.
It really does. This hospital-acquired or iatrogenic anemia is a common and frankly entirely preventable pitfall of inpatient management. It might even necessitate an unnecessary simple blood transfusion just to replace what we took.
Exposing them to transfusion risks.
Exactly. Alloimmunization, reactions, all from potentially avoidable blood draws. Labs should be strictly driven by a change in clinical status, a specific suspicion of a new complication, or maybe the need to monitor a specific therapy, not by simple habit or clicking the daily labs box in the order set.
Great point. Okay, what about oxygen? Often feels like the default supportive intervention for almost any hospitalized patient, regardless of diagnosis.
Yeah, the ubiquitous nasal cannula. But supplemental oxygen is not routinely indicated for an uncomplicated VOC. It must be reserved strictly for patients who have documented hypoxemia.
So actual low sats.
Actual low sats. Those with an SPO consistently below, say, 92 to 94%, or showing clear signs of significant respiratory distress.
And why not just give it prophylactically?
Well, giving oxygen when the saturation is already normal can actually suppress the patient's own respiratory drive, theoretically. More importantly, perhaps, it doesn't provide any real benefit in uncomplicated VOC, and it can mask an early, subtle sign of a developing complication, like acute chest syndrome.
Which is often defined in part by new hypoxia.
Exactly. If you've got them on oxygen already, you might miss that early drop in saturation that signals ACS is brewing. So only for documented hypoxemia.
That shifts our focus perfectly to prophylaxis against those leading complications during the inpatient stay. And we know acute chest syndrome, ACS, is the big one, the monster we absolutely must try to prevent. It's a major cause of morbidity and too often mortality.
Absolutely. It's the #1 killer in SCD, often. And the good news is there's a strong guideline from the NIH expert panel report that mandates a really low-cost universal intervention.
Which is?
Incentive spirometry. It is strongly recommended for all patients admitted with VOC. Doesn't matter what their initial lung symptoms are, doesn't matter what their admission chest x-ray looks like, everyone gets it.
And the rationale there, preventing atelectasis.
Precisely. It helps prevent atelectasis, that collapse of small airways, because those collapsed areas can then become occluded by sickled cells, creating a perfect setup for inflammation, infection, and subsequent full-blown ACS.
So we need to ensure adherence.
We need to ensure that nursing and respiratory therapy adherence to this is basically 100%, from admission right through until discharge planning. And clinically, we need to remain vigilant. Suspect ACS if you see any new pulmonary infiltrate on chest imaging, especially if accompanied by fever, chest pain, cough, tachypnea, or, as we just discussed, new hypoxia.
Okay. The other ever-present threat during admission is infection, leading to sepsis. Given the functional asplenia that's characteristic of SCD, any fever, any sign of systemic illness has to be treated like an emergency.
Has to be. That functional asplenia leaves these patients incredibly vulnerable, especially to encapsulated organisms like strep pneumo, H. flu, Neisseria meningitidis.
Yeah.
Infection is not only a frequent trigger for the crisis itself, but it's also a dire complication of the crisis or hospitalization. Therefore, any febrile patient requires prompt, comprehensive evaluation.
What does that involve?
Blood cultures, certainly, a chest radiograph if there are any respiratory symptoms or signs, urine studies if indicated, and crucially, the early initiation of empiric broad-spectrum antibiotics.
Don't wait for cultures.
Do not wait. You have to treat them as high risk for sepsis until proven otherwise, often starting with something like a third-generation cephalosporin, maybe with atypical coverage depending on the clinical picture.
Okay, so while the immediate focus is often pain and maybe infection watch, we have to maintain vigilance for those other critical, maybe less common, but equally life-threatening events throughout the hospital stay.
Indeed. Continuous clinical vigilance is key. We need to actively screen for splenic sequestration, particularly in children and young adults.
How does that present?
Typically a rapid drop in hemoglobin, often quite profound, combined with a rapidly enlarging tender spleen. It's an emergency requiring urgent transfusion.
Or else.
We need continuous monitoring for any new neurological deficits. That could signal an acute stroke, another emergency requiring immediate action. And we must also screen for a plastic crisis.
Often linked to parvovirus B19.
Exactly, often associated with parvovirus B19 infection. This presents as profound anemia, but uniquely coupled with marked reticulocytopenia. The bone marrow just shuts down temporarily, unable to compensate for the ongoing hemolysis.
And all of these demand immediate targeted intervention beyond just pain management.
Absolutely. Specific, often emergent interventions.
Okay. And when those interventions involve blood products, we move into the highly strategic and sometimes controversial use of transfusion therapy. Let's clarify the indications, because as you mentioned regarding iatrogenic anemia, transfusion is often overused in uncomplicated pain crises, and it carries its own significant risks.
That boundary has to be crystal clear for everyone on the team. Transfusion is not indicated for managing an uncomplicated VOC pain crisis, period. Nor is it indicated simply for chronic baseline anemia unless the patient is highly symptomatic from it, or perhaps requires an invasive procedure where a higher hemoglobin is necessary.
So when is it indicated?
Transfusion is reserved for specific, high-risk, acute indications. Things like severe symptomatic anemia, typically we're talking a hemoglobin below 6 or 7 grams per deciliter or a rapid drop. Acute chest syndrome, particularly if it's moderate to severe, and acute stroke.
Okay, and we also need to emphasize the timeline, right? Does timing matter?
Timing matters hugely. The data clearly supports urgency when transfusion is indicated for these severe complications. Early transfusion, generally defined as within 24 hours of admission, is associated with demonstrably improved outcomes.
Such as
Reduced length of stay, lower overall costs, decreased mortality rates, and lower rates of subsequent sepsis. So if the indication is met, we really need to overcome any logistical hurdles with the blood bank and move quickly.
Okay. Once that decision to transfuse is made, We then face the critical choice.
Yeah.
Simple transfusion versus exchange transfusion. This is where the goals of therapy really dictate the specific intervention, doesn't it?
Absolutely. They have fundamentally distinct objectives and mechanisms. Simple transfusion is appropriate when the primary goal is simply restoring oxygen carrying capacity.
So just topping off the tank.
Exactly. Think symptomatic severe anemia, maybe acute splenic sequestration after initial stabilization, or perhaps mild to moderate ACS where you just need a boost. We are simply adding red cells.
But there's a caveat.
A major caveat. We must proceed with extreme caution if the patient's baseline hemoglobin is already on the higher side for them, say 8 or 9 GDL. Giving a simple transfusion in that setting can raise their total hemoglobin too high.
Causing hyperviscosity.
Exactly, causing a dangerous increase in blood viscosity.
And that hyperviscosity then potentially increases resistance to flow, could precipitate further vaso-occlusion, essentially worsening the crisis you were trying to treat.
Precisely, which is why exchange transfusion exists. Exchange transfusion is the preferred intervention when the goal is the rapid reduction of the circulating sickle hemoglobin, the HbS percentage, without significantly increasing the total hemoglobin and viscosity.
How does it do that?
It simultaneously removes the patient's own HbS-containing red cells while infusing healthy HbA-containing donor red cells. It effectively swaps out the bad cells for good ones.
And when is this critical?
It is absolutely critical for severe refractory acute chest syndrome, especially if there's progressive hypoxemia or impending respiratory failure. And it is the absolute mandate for an acute ischemic stroke in a patient with SCD.
What's the specific therapeutic target we're aiming for with an exchange transfusion? How much HbS do we need to remove?
The primary target is to rapidly reduce the HbS level to less than 30% of the total hemoglobin, sometimes even lower in critical situations like stroke. We also typically aim to maintain the total hemoglobin concentration at or below 10 GDL to mitigate that risk of hyperviscosity we just talked about.
And this requires specialized capabilities.
Yes, it requires apheresis equipment and significant coordination with the blood bank, and often a hematology consult. It cannot be performed in every hospital.
That urgency regarding acute stroke management. It needs to be crystal clear for any hospitalist receiving a patient with new neurological symptoms and SCD.
It absolutely does. It is a time-is-brain emergency, truly akin to managing large vessel occlusion strokes in the general population. For acute stroke and SCD, exchange transfusion must be initiated emergently.
Don't wait for imaging.
It should not be delayed waiting for definitive cerebral imaging confirmation like an MRI if the clinical picture new objective neurological deficits is convincing. Time is tissue.
What if your facility can't do an exchange emergently?
If your facility lacks the capability, you must immediately start a simple transfusion as a bridging measure to at least get some healthy cells in while simultaneously arranging urgent transfer to a center that can perform the exchange. Delaying that reduction of HbS leads directly to worse neurological outcomes. No question.
Okay, vital point. Now, since these patients, unfortunately, are often frequent recipients of blood products throughout their lives, let's address the mandatory safety considerations around transfusion itself. Alloimmunization is a huge issue.
It's a massive issue. This is a non-negotiable safety mandate. The rate of alloimmunization developing antibodies against non-self red cell antigens in the SCD population is extremely high, can be as high as 30 to 40% in some studies.
Wow.
So we absolutely must mandate extended phenotypic matching for all transfused patients with SCD.
Meaning beyond just ABO and Rh type.
Far beyond. It means matching for major red cell antigens like KEL, KID, Duffy, sometimes S. The blood bank needs to provide antigen-negative units for any clinically significant antibodies the patient may already have, and prophylactically match for common ones to prevent new antibody formation.
Why is this so critical?
Because developing these allo antibodies puts the patient at incredibly high risk for delayed hemolytic transfusion reactions, or DHTRs.
Explain those.
That's where their body mounts an immune response and attacks the transfused red cells days or even weeks after the transfusion. It can cause hemolysis, anemia, pain, sometimes triggering a crisis even worse than the one that led to the initial admission. It can be devastating.
So extended matching prevents this.
It significantly minimizes the risk. This coordination with the blood bank, yes, it takes extra time and effort, but it is absolutely essential for the long-term safety and well-being of these patients.
Okay, that brings us logically to the final major phase of the admission. Utilizing this inpatient stay, not just to treat the acute crisis, but really seeing it as a critical opportunity. An opportunity to review and ideally optimize their long-term disease-modifying therapy, or DMT.
Yes.
Because we know that underutilization and non-adherence to these crucial therapies remains a major issue in clinical practice.
This is perhaps the single highest value intervention a hospitalist can perform for a stable patient admitted with VOC, beyond managing the acute issues. It's about the future.
Right.
And the cornerstone therapy, the foundation, remains hydroxyurea, HU. It is the undisputed first-line disease-modifying agent for adults who experience frequent crises.
Typically defined as 3 or more a year.
Yeah, typically 3 or more significant pain events per year, or for anyone who has experienced recurrent acute chest syndrome. And, crucially, it should be offered to all children with the severe phenotypes, that's HBSS or HBS thalassemia, starting as early as 9 months of age, regardless of their current symptoms.
9 months. That early, why?
Because the evidence is overwhelming that starting early prevents irreversible organ damage that begins accumulating even in infancy.
Okay. What's the mechanism of action that makes hydroxyurea so effective? How does it actually work?
HU is fascinating because it actually works via multiple pathways, which is probably why it's so robust. Its primary and most recognized action is inducing the production of fetal hemoglobin HbF.
And HbF interferes with sickling.
Exactly. HbF inhibits the polymerization of HbS within the red cell, making the cells much less likely to sickle, even under low oxygen conditions. But it also has other key benefits. It seems to increase nitric oxide bioavailability, improving blood flow. It acts as an anti-inflammatory agent, reducing some of that chronic inflammation we talked about. It might even decrease red cell adhesion.
So multiple hits.
So multiple beneficial hits. And these combined actions result in massive proven benefits. A significant reduction in crisis frequency, decreased incidence of ACS, far fewer hospitalizations, less need for transfusion, and just improved overall quality of life and survival.
Okay. So as hospitalists managing a patient admitted with VOC who is already on hydroxyurea, what specific monitoring should we be checking during the admission? And what should prompt us to maybe hold or adjust the dose?
Good practical question. The key monitoring requirement for HU is regular CBC and reticulocyte count checks, usually done every 1 to 3 months outpatient, but worth checking on admission and maybe before discharge. We're primarily monitoring for dose-limiting myelosuppression.
Affecting which cell lines?
Mainly neutrophils, but also platelets and sometimes red cell production. Specifically, we watch the absolute neutrophil count, the ANC. If the ANC drops below 2,000 cells per cubic millimeter, or some protocols use a more conservative threshold of 1,000, or if the platelet count drops significantly, say below 80,000, then the dose must be temporarily held or significantly reduced. Conversely, if a patient comes in, they've been on a stable dose, but their hemoglobin and MCV, mean corpuscular volume, which typically increases with HU, remain low, and they're still having crises. The admission might be the perfect time to liaise with hematology and initiate a dose escalation plan, assuming they are adherent and haven't hit those toxicity limits, of course. Maximize the benefit.
Right, use the opportunity. Now, for those patients who are either intolerant of hydroxyurea due to side effects, or perhaps have an inadequate response despite being on a maximal dose, those really difficult to manage adults who just keep cycling back to the hospital. We now have some adjunctive agents, right? What are the key players there?
We do, thankfully. We currently have 2 important FDA-approved adjunctive agents available. The first one is L-glutamine.
L-glutamine.
Yes, it's indicated for patients 5 years and older who continue to have recurrent pain events despite being on hydroxyurea, or those who simply cannot tolerate HU.
How does L-glutamine work?
It's an oral powder taken twice daily. It works, we think, primarily by supporting cellular antioxidant capacity within the red blood cells. It helps replenish NAD, which is important for reducing oxidative stress, maybe helping to stabilize the red blood cell membrane and reducing those pain events.
And the appeal.
A major appeal is that it generally does not require the same stringent laboratory monitoring for myelosuppression that hydroxyurea does, making it a bit simpler in that regard.
Okay, and the newer biological agent, that one targets the cell adhesion process we discussed way back at the beginning.
Exactly. You're thinking of crizanlizumab. That's a monoclonal antibody given intravenously that specifically targets P-selectin.
Remind us about P-selectin's role.
P-selectin is a molecule expressed on activated endothelial cells and platelets, and it acts like Velcro, facilitating those sticky interactions between sickled red cells, leukocytes, platelets, and the endothelium itself. Those interactions are key drivers of vaso-occlusion.
So crizanlizumab blocks the Velcro.
Essentially, yes. By inhibiting P-selectin, Crizanlizumab reduces the frequency of those multicellular adhesive interactions and consequently reduces the frequency of vaso-occlusive crises.
Who is it for?
It's reserved for patients 16 years and older who are still having frequent crises despite being on, or intolerant of, hydroxyurea. It's administered as a monthly IV infusion. So it represents a really powerful step-up therapeutic option for some of our most complex and frequently hospitalized adult patients.
Good to have those options.
Yeah.
Now, it's probably important we quickly address voxelotor because listeners may have seen that used previously, particularly for managing the chronic anemia aspect.
Yes, that's an important point of clarification. Voxelotor was an oral agent. Its mechanism was different. It aimed to increase hemoglobin's affinity for oxygen, thereby directly inhibiting HbS polymerization and reducing sickling and hemolysis. It did raise hemoglobin levels. However, it was voluntarily withdrawn from the U.S. market by the manufacturer in 2024 due to safety concerns identified in post-marketing studies. So as of now, it's no longer part of our therapeutic armamentarium in the U.S.
Okay, good to know. So our current DMT strategy remains firmly rooted in hydroxyurea as the foundation.
Absolutely.
With L-glutamine and crizanlizumab as targeted step-up or adjunctive options for specific patient groups.
Correct. That's the current landscape.
Okay. Finally, we have to ensure that before that patient walks out the hospital door, we've rigorously covered all the necessary secondary prevention steps. The goal here is minimizing the chances of that dreaded 30-day readmission, which is notoriously high in this population.
This focus on secondary prevention and discharge planning is absolutely where we can truly break that frustrating readmission cycle. It's not just about fixing the acute problem.
What are the high-value prevention components?
Well, rigorous stroke prevention is non-negotiable, particularly for children aged 2 to 16 years. They absolutely must receive annual transcranial Doppler, or TCD, screening.
Explain TCD screening briefly.
TCD is an ultrasound technique that measures the velocity of blood flow in the major cerebral arteries. Abnormally high velocities, usually defined as 200 centimeters per second or greater, indicate significant stenosis or turbulent flow, which correlates with a very high risk of future stroke.
And if the TCD is abnormal?
If TCD velocities are consistently abnormal, or if the patient has already had a stroke in the past, then chronic red cell transfusion therapy is indicated. The goal is to keep the HbS level consistently low, typically below 30%, to dramatically reduce their stroke risk.
And chronic transfusion, of course, as we hinted at earlier, introduces its own long-term challenge: iron overload.
Precisely. You solve one problem, potentially create another, if not managed proactively. Chronic transfusion absolutely necessitates rigorous monitoring and management of iron overload. That means regular serum ferritin levels, often liver iron content assessment, like MRIT2, and frequently requires concurrent iron chelation therapy to remove excess iron and prevent damage to the liver, heart, and endocrine organs.
Highlights the need for close hematology follow-up.
Absolutely essential. This isn't something managed solely by primary care or the hospitalist during admissions.
Okay. And finally, infection prophylaxis. Starts in childhood but needs lifelong attention through immunizations, right?
Absolutely. Penicillin prophylaxis, usually twice daily penicillin VK, should continue for all young children with SCD, typically up to at least age 5, to prevent life-threatening invasive pneumococcal disease.
And beyond age 5.
Beyond age 5, the focus shifts heavily to maintaining adherence to a comprehensive, up-to-date immunization schedule. This is critical for both adults and children due to that functional asplenia.
Which vaccines are key?
The pneumococcal vaccines are crucial, both the conjugate, PCV, and polysaccharide, PPSV23 series. Meningococcal vaccines covering serogroups ACWY and D, and of course the annual influenza vaccine. As hospitalists, we should ideally verify their immunization status during the admission and facilitate administration of any needed vaccines before discharge, if possible.
Okay. To wrap up the inpatient stay then, the discharge planning process itself has to be more than just handing over prescriptions. It needs to transition seamlessly from acute management to setting them up for long-term success outpatient.
It really is the final safety net, and it's absolutely crucial for mitigating that recognized, persistently high risk of 30-day readmission. Discharge planning must be comprehensive. It must include thorough patient education, checking their understanding of recognizing early symptoms of crisis or complications, reinforcing strict adherence to all their medications, especially the disease-modifying therapies, including confirming they have access and can afford them. Practical advice on avoiding their known common triggers: dehydration is huge, overheating, sudden temperature extremes, overexertion.
And the follow-up plan.
Most critically, a structured, multidisciplinary outpatient follow-up plan, must be established before they leave. This means confirmed appointments, ideally soon after discharge, with both their hematology team and their primary care provider. We need to actively close that loop on care coordination to prevent them from slipping through the cracks and just cycling right back into the ED a few weeks later.
That was indeed a comprehensive deep dive into what are clearly highly specialized and, in some areas, rapidly evolving management protocols.
There's a lot to cover.
It is. But for the hospitalists listening, I think the essential action items really boil down to a few key things. Remember, VOC diagnosis relies purely on patient report. Trust your patient. Pain management must be rapid, yes, but also individualized based on their prior effective regimens. We need to be aware of the ongoing discussion and potential advantages of using balanced fluids like LR over normal saline, even if definitive proof is pending. Instead, spirometry needs to be universal prophylaxis for ACS for every admission.
Every single one.
We must consciously avoid those unnecessary daily labs to mitigate iatrogenic anemia. And critically, we absolutely must use the admission, use that time, as a chance to optimize hydroxyurea or facilitate discussion about stepping up to adjunctive disease-modifying therapies like L-glutamine or crizanlizumab for eligible patients who are still struggling.
Well summarized. And perhaps that leaves us with a final provocative question for you, the listener, to consider as you go back to your clinical practice. Given that hydroxyurea is the definitive first-line disease-modifying agent, yet we have these newer options like p-selectin inhibitors and L-glutamine being increasingly utilized, what metrics, beyond just crisis frequency, should we as hospitalists be using to determine which patients truly need a definitive step-up therapy review during their inpatient stay? How do we identify them early to really move the needle on their long-term morbidity and organ protection, not just count crises?
The vital point. How do we proactively identify those needing escalation, bridging the gap between evidence, access, and maybe institutional inertia? Thank you for taking this essential deep dive with us today.
Always a pleasure. We sincerely hope this discussion helps refine your local inpatient protocols and ultimately improves outcomes for your patients with sickle cell disease.